Hello students, so welcome to today's session. We have an integrated session for the upcoming INI in which we are together with Orthopedics and Radiology. So I'm very pleased to introduce you Dr. Yusuf Tyagi. He is our Orthopedics faculty at Next, and I'm Dr. Rishabh Jain, your Radiology faculty at Next. So welcome to today's session. Yusuf sir, over to you.
Thank you sir, thank you for the kind introduction. It is also important for the students to recognize that what is the reason behind this integration session.
Right, sir.
So
right.
that, it is important to have a discussion of the previously asked questions, the previous year asked questions, so that they can understand it in a better frame, in a better way, and to mark the answer correctly.
Right, sir. Right, sir.
So, without wasting too much of the time, sir, let's have a discussion on the first question itself.
Yes, sir. And at the outset, I would just like to tell you that we have planned this integrated session in a way that all the important topics which have been asked in previous INIs are covered in some form of the other. So maybe we'll not cover all the questions, but each and every topic will cover in the form of options in the given questions. And so the main purpose of this today's class is to familiarize you with all the important topics just before the exam. So let's start, sir.
Exactly, sir. Like the question number 1 is, 32-year-old male came to OPD with a complaint of low backache. Now this is one such clinical feature which is mentioned in the question. Limited chest expansion, another associated clinical feature. Red eyes, a very important and a key clinical feature on the basis of which you have already made the diagnosis. This is the question which is just we have copy pasted like the previous in the most recent INI-CET examination. This was the question which was asked. And the essence of this question, the reason why we are analyzing this question is to discuss about the differentials which are provided in the options.
Right, sir. Right, sir.
So, sir, before we talk about the differentials, because the X-ray is also provided over here. So, what are those findings which are relevant in order to make or to carry forward with the diagnosis?
Yes, so we'll just discuss the X-ray briefly first.
Yes.
Okay, so in the X-ray, what do we see? It is a given spine X-ray, and we are suspecting a patient of low backache. So we'll first see the SI joint and we'll first see the disc space. Okay. Now what do we see in the bilateral SI joint? So bilateral SI joint, you see that they are narrowed. In fact, on the right hand side, you see that the joint space is calcified. That is, the bones are fused. So it is an ankylosis, a bony ankylosis on the right side. And on the left side of the SI joint, you see that there is joint erosion and joint space narrowing. Okay, so this means that it is bilateral sacroiliitis. Okay, we have clear on this point. Now, another abnormality on the X-ray we can see in the spine, that the spine is fused. There are these bridging syndesmophytes. Okay, giving it a bamboo spine appearance. Okay, giving it a bamboo spine appearance. And also you see that there is calcification at the interspinous at the disc level. So this is bridging syndesmophytes giving a bamboo spine appearance, and we see bilateral sacroiliitis.
And yes, sir, as you have very correctly said, bridging syndesmophytes, calcification of the intervertebral discs.
Yes.
And every soft tissue which is present around the vertebral column will be calcified.
Yes,
in this particular kind of the X-ray. So now let's have a discussion on the differential diagnosis.
Okay.
Now the first differential which is over here is obviously the ankylosing spondylitis, and if you are sitting in this examination, you already are aware the answer is the ankylosing spondylitis. Now what are the important facts that you cannot neglect at any point of given time related to this topic? Point number 1 is the age. It is always a disease which is considered to be of early onset, like 20 to 25 years of age, and males are more predisposed to get these diseases in comparison to the females. Sacroiliitis is considered to be the key component in making the diagnosis. Imagine if the patient is having a low backache, where we are suspecting him to be suffering from ankylosing spondylitis. If sacroiliitis is not there in any form, if it is not provided, then you can safely rule out ankylosing spondylitis. All right. Disability, loss of spine extension with the progressive kyphoscoliotic deformity, but loss of spine extension is always the earliest disability that the patient of ankylosing spondylitis will have. All right. Limitation of spine extension. Then limited chest expansion because of the fusion of the costochondral junction. There will be a limitation of the inspiratory drive and the patient would be having breathlessness episodes. Enthesopathy is considered to be a key clinical component because in case of a patient who is suffering from ankylosing spondylitis, there are calcifications of the tendinous insertion away from the axial skeleton. Like, Achilles tendon insertion might get calcified. So these are the enthesitis, enthesopathy. So the patient could be having a distant pain at the site of tendinous insertion because of its calcification. Like these diagnostic criteria, New York criteria, ASAS criteria, we have already discussed in the previous sections also, and these are in order to frame the clinical based diagnosis of ankylosis, and obviously the extra articular clinical features, like like acute anterior uveitis, which is considered to be the most common clinical aspect. Apart extra articular feature for ankylosing is like glaucoma, cataract, the third degree cardiac insufficiency, aortic insufficiency, right? Like apical pulmonary fibrosis, the prostatitis, retroperitoneal fibrosis. So all of them are the extra articular clinical features which are extremely important for you to remember, because every time you are going to get the question related to this topic, there is always a possibility that you might also get these kind of hints which is provided to you in the question. All right, so acute anterior uveitis is considered to be the most common extra articular manifestation of ankylosing spondylitis. So with this, we have talked about this ankylosing spondylitis clinical feature. Now, sir, over to you, how to identify this ankylosing spondylitis on the X-ray provided.
Yeah, so X-rays of spine are very important, first of all. And amongst the X-ray of spine, spondyloarthropathy are very important topic. Okay, so most common spondyloarthropathy that is given to you in the exam is an ankylosing spondylitis. And first, in a low backache X-ray, when you are giving an AP view of the lumbar spine along with hips, you have to see the SI joint. ठीक है, students make this mistake कि SI joints तो हम देखते ही नहीं है, हमें तो lumbar spine और hips देखने की आदत है, but SI joint बहुत important part है एक spine और pelvis X-ray के. तो इस X-ray में, in the given X-ray, we see that there is loss of joint space. So there is loss of joint space in bilateral SI joint along with erosions. Okay, along with these erosions. So remember, SI joint involvement in ankylosing spondylitis is an early feature. Even when the spine is normal, the bilateral SI joints are involved. Okay, earlier than the spine. And in the SI joints, just an extra pointer, the iliac side is involved more than the sacral side. Okay? The iliac side of the SI joint is more commonly involved than the sacral side in the SI joints. Now, secondary, after SI joint involvement, what are the findings on SI joints? First, there will be joint space widening, because earlier there is synovitis, right? So in SI joint, we have a synovial part and a fibrous part. So ankylosing spondylitis involves the synovial part of the SI joints, and so in synovitis the joint space might not be reduced, but as slowly the disease progresses, there are erosions along the SI joint. As you can see in this image, there are these erosions along the SI joint, and there is this joint space narrowing, and later on the SI joint fuses. So there is bony ankylosis. There is bony ankylosis at a later stage. And after SI joints, we come to the spine. Now, in spine, what are the features that we study? So, remember, the key word is bridging syndesmophytes. Bridging syndesmophytes. Syndesmophytes. And now, what are these? So, suppose these are two vertebrae. These are two vertebrae. The typical area of involvement is this area. Okay, these are called as syndesmophytes. Now, sometimes what you will see these types of osteophytes. These are osteophytes. These are not syndesmophytes. Syndesmophytes are parallel to the margins of the vertebrae. So remember the term bridging syndesmophytes, which gives the appearance of a bamboo spine. Okay. And after that, what you have to remember is the soft tissue involvement. So there is ossification along the interspinous ligament, and that interspinous ligament runs in between the spine. So this gives a dagger sign. This gives a dagger sign on lumbar spine X-rays. And the third point that we have to mention is calcifications of soft tissue. So one we read interspinous ligament calcification, and then enthesopathy, as sir rightly mentioned, soft tissue calcification at the tendinous insertion sites. Right, sir, over to you.
All right, sir. So hopefully you get the overview, like what exactly are the X-ray findings of the ankylosing spondylitis in order to identify it. Now comes a point where we are going to get the differential of ankylosing spondylitis, which is always mentioned in the other options. Like one of the differential is DISH syndrome. It is diffuse idiopathic skeletal hyperostosis. You see, as the name indicates, it is diffuse, all right, idiopathic, like there is no etiology identifiable, skeletal hyperostosis. So there is a characteristic ossification pattern which is involving the spine more commonly.
Right, sir.
As far as enthesis is concerned or enthesopathy is concerned, it is relatively rare in case of DISH syndrome compared to ankylosing spondylitis. That is the one difference. Second is, there is a specific involvement of the anterolateral aspect of the thoracic spine. Now, there is a provided theory that, because of the descending aorta pulsations, the left sided of the thoracic spine is not affected or not commonly involved, but there is a peculiar involvement of the right side of the spinal thoracic segment. That is point number 2. Now, this syndrome is found to be associated with systemic conditions like gout, hyperlipidemia, and diabetes mellitus because of its association with HLA-B8. You see, HLA-B27 association is found in case of ankylosing spondylitis.
Right,
HLA-B8 association is found in case of diabetes mellitus,
right,
as well as in case of DISH syndrome. So they are found to be associated, both of them. So these are those catch points on the basis of which, if it is provided to you in the question, you will be identifying that possibly this time the examiner is not asking about ankylosing spondylitis, he is asking about DISH syndrome possibly.
Yes, sir.
All right. As far as the differences are concerned, sacroiliitis, too much we have discussed, too much importance of the sacroiliitis or the involvement of the sacroiliac junctions in the ankylosing spondylitis been already discussed. There will be no fusion. You see, like all the soft tissues were getting calcified in case of AS, but in case of DISH syndrome, there is not going to be any fusion. Like disc space would remain preserved. And finally, the age, the differences in the age as far as presentations are concerned.
Right, sir. I think radiological findings are also discussed here. The main important point is that SI joints are spared. SI joints are spared in DISH, elderly involvement, disc is not calcified, and very important, the calcification is along the anterior longitudinal ligament. So it is along the anterior surface of the spine only. And remember, the diagnostic criteria of DISH says that 4 contiguous vertebra should be fused.
Exactly.
So there should be bridging osteophytes along 4 contiguous vertebral bodies. Okay? So then we call it DISH, right?
And sir, there is also no involvement of the intervertebral disc space.
Yes.
Like there is no continuity of the calcification along the vertebrae.
Right,
so this is how you are going to differentiate
between the DISH and ankylosing.
So hopefully you are getting the real answer, like on what basis you are going to mark the answer accordingly. Now, yes, another differential diagnosis is multiple myeloma.
Right.
You see, nowadays, because the questions are getting more and more clinical, so instead of asking about the exact diagnostic criteria, what they are giving you are the clinical triads in multiple myeloma related question. All of us are aware of the fact that it is a plasma cell tumor. 1, old age involvement, like beyond 60 years of age. 2nd, low backache, because multiple myeloma more commonly involves the lumbar vertebrae. So low backache involvement, low backache will be the clinical presentation. But hypercalcemia. You see, another very important feature is the hypercalcemia. So it is considered to be a clinical triad for presentation as far as multiple myeloma is concerned. You see, if a patient comes to you with a low backache, having old patient, age of the patient is higher, and he is having hypercalcemia, it is considered to be multiple myeloma until proved otherwise.
Right, sir. Right. A typical age presentation with hypercalcemia, renal failure, anemia, bone lesions, what we typically call CRAB criteria, fits into clinical profile of a multiple myeloma rather than a spondyloarthropathy or DISH kind of a picture. And even in the given X-ray, you see that if you're given a case of multiple myeloma, you'll typically see these lytic lesions in the vertebral body. And in the given, along with the given clinical profile, multiple myeloma diagnosis can be safely made, sir.
Exactly, sir. And in case of question, like if they are going to ask you about the question related to multiple myeloma, there will be a hint provided in the form of anemia, fatigue, there will be weight loss, confusion. So all these things are going to be provided in order to make the correct answer related to that. Another very important differential, sir, is tuberculosis. Tuberculosis is such a common phenomena that is happening in our country. Like you have to consider a patient might be suffering from tuberculosis, every patient, and you have to search for it until and unless these findings are getting more and more evident on the X-rays. So the clinical features are simple. It is going to be associated with constitutional feature. There will be a history of fever, persistent, given to you. Pain more at night will be provided to you. There will be weight loss. There will be loss of appetite. So all those things are going to be provided in the form of clinical features. Now X-rays, sir is going to discuss that how they are going to be different from the prototype question that we are providing, like ankylosing spondylitis.
Yes, so in a systemic condition, so ankylosing spondylitis, as we earlier mentioned, is a systemic condition. So it will be a multi-level involvement. First, okay, more joints will be involved. But in port spine, what is typically described is a spondylodiscitis. Remember the term spondylodiscitis, which means that the disc and the adjacent vertebrae will be involved. Since it's an infection, it will be a localized area. So what do we typically see here? We see on a eyeballing or an overall glance that this part of the X-ray is abnormal. Rest of the spine appears normal. The intervertebral disc space here is normal. These vertebrae are normal. So we are looking at a focal pathology. So ankylosing spondylitis is unlikely. And in this focal pathology, what do we see? We see that this disc space is narrowed. Its adjacent vertebrae is destroyed. The end plates are destroyed. It is sclerosed. So remember, these are the features which favor an infectious pathology, and with the background of a low back ache, a fever, fatigue, loss of weight, you can presume it to be a diagnosis of TB, and an MRI spine would confirm the diagnosis.
Exactly, sir. Olaf, you are asking about that. What is the clinical feature of DISH? The clinical feature for all the 4 conditions that we are discussing remains the same. That is low back ache. And there are so overlapping of the clinical features, you cannot distinguish it or you cannot differentiate it until and unless you know the thin differences in all those differentials. And this is exactly what we are discussing. All right. So low backache remains the consistent clinical feature for any patient coming to you with any of these conditions. Hopefully you get the answer. Now, hopefully you'd be able to mark the correct answer if any of these are provided to you in the form of a question.
Yes, and the difference between DISH and ankylosing spondylitis is also the age, right? So as sir mentioned earlier in the question, ankylosing spondylitis affects young males. So people like you, people like me, these are the sufferers of ankylosing spondylitis. Whereas DISH affects the elderly population, right?
Towards the elderly.
Yes.
There is an involvement in case of DISH syndrome. All right. Thank you, sir. Hopefully we get the
Yes, I think we should meet. Yes, sir.
Let's talk about the next question then.
Right, sir. Right.
Like in this question, again, every time you are sitting in this examination, you are getting this question. Like 40-year-old male, they gave you the age and then they are asking about the diagnosis by provision of the X-ray. All right. So first, sir, you have to discuss the X-ray.
So the thing with bone tumors is that they just give you the age and the X-ray, like no clinical features, nothing. Age and an X-ray will make the diagnosis of a bone tumor as simple as that. Okay, so let's just discuss the X-ray here in just a brief description. So what do we see here? We see a lytic lesion. First of all, it is a black looking lesion. In radiographic terms, what do we see it? We call it a lytic lesion. And what are the further characteristics? It is a skeletally mature skeleton X-ray. So you see that the physis has fused, and there is a lytic lesion involving the lower end of the femur in the lateral condyle of the femur. You see that the margins are relatively well defined. There is a narrow zone of transition. In radiological terms, we call it a narrow zone of transition. And here the cortex is intact. And this lytic lesion, very, very important, is reaching till the articular surface. So remember, lesion reaching till the articular surface. And if you see this buzzword in the question or even in the image, you can safely mark the answer as a giant cell tumor. Okay, this has been repeatedly asked again and again in the exam. Sometimes they'll give you an X-ray of the distal end of radius, distal end of ulna, distal end of knee, proximal tibia. Anywhere in the body GCT can occur, even in pelvis GCTs occur. But remember this very important point, it reaches till the articular surface, especially in a long bone. Okay, sir?
Exactly, sir. Like too much of the discussion related to this lytic lesion. Like for us as an orthopedic surgeon, we just try to see that if it is encroaching all the way up to the level of joint, it is an epiphyseal lesion. And epiphyseal lesion, if the growth plate is still visible, it is less than 20, so it goes in the favor of chondroblastoma. If it is more than 20, then it goes in the favor of
Giant
GCT.
cell tumor.
So let's have a discussion on the differential, sir,
Right,
because these are also very important. Like first one is the giant cell tumor. Now what all you need to remember, epiphyseal tumor, you need not to remember all the other forms of the epiphyseal tumor. Just remember GCT and chondroblastoma.
Right, sir. Right, sir.
Less than 20 years of age, chondroblastoma. More than 20 years of age, GCT possibly.
As simple as that.
As simple as that.
Right.
So how to identify whether the X-ray is that of a less than 20 years? By looking at the growth plate. If the growth plate is still visible, it is chondroblastoma.
Right,
if
sir.
growth plate is obliterated, it is giant cell tumor.
Right, sir.
All
Very
right.
well said.
So, so this point hopefully is covered. Now, next point is metaphyseal tumor in case of children. If they ask about any rare phenomena, like exceptions, so it can also appear as a metaphyseal tumor, but it is a very rare phenomena. It's not common, it's a rare phenomena. And this too happens only in case of a child. And there is a theory which is considered to be a hypothetical one, that it has originated from the epiphysis, it has encroached all the way up to the metaphysis because of the barrier of the growth.
Right, sir. So it is a meta-epiphyseal lesion, as to say. Rest of the lesions that we talk about are meta-diaphyseal.
Yeah.
But meta-epiphyseal lesions are very rare.
Very rare.
And as sir said, two important things you have to remember: GCT and chondroblastoma. And age helps you tackle that question.
Yeah.
Right, sir.
So it's an aggressive benign tumor. We all know that Anaking has classified the benign tumors into latent, active, and aggressive. And giant cell tumor is a characteristic aggressive benign tumor, which is having a 5% possibility of turning into a malignant tumor also. This is the kind of the tumor which can go or turn malignant. So malignant tumors in which it could be converted is osteosarcoma and the fibrosarcoma. Simple. These are the two malignant tumors. Now, can metastasize as a benign tumor also? GCT can metastasize. This is the question which was asked in INI-CET in the November session.
And sir, interesting point. This exact thing was asked to me in my orthopedic final viva by the consultant, ki which benign tumor of the bone can metastasize. And at that point, to be frank, I did not know the answer to that question, and my viva ended at that point. Okay. But important point to remember for you, it has been asked in the previous year questions, and it is a typical favorite pointer of an examiner, especially of AIMS. So remember what sir says, it can metastasize.
A benign tumor which can metastasize,
Right,
but the specificities which are involved in this, that not all GCT can metastasize. Only a distal radial one will metastasize.
Okay.
All right. Distal radial, and the most common site which is receiving this metastasis are the lungs.
Bilkul. This was also asked to me in my exam.
All right. So GCT as a benign tumor can metastasize, but it has to be a distal radial GCT, and it can metastasize to lungs. Lungs are the most common recipients, and yes, as we have already discussed, it can turn malignant. All right. 5% are the possibilities that GCT can turn into a malignancy. So these are the things. Now, sir, over to you that how to identify a GCT and how to distinguish. Although sir has very well explained it to you, the clinical core features of this.
I think just 3 words I would say: lytic lesion, skeletally mature child, reaching till the articular surface. Okay? These 3 buzzwords, these 3 keywords, always keep in mind when you are linking GCT with a bone tumor: as reaching till the articular surface, lytic lesion, and a skeletally mature patient. Okay?
Hopefully, discussion of the GCT is over. Yeah, another differential that could come in our mind is as that of the aneurysmal bone cyst. Aneurysmal bone cyst is the involvement of metaphyseal region. It is not epiphyseal tumor. Primary involvement of the metaphyseal region, and that too in less than 20 years of age. And aneurysmal bone cyst, one of the characteristic finding which could be always be provided, like it is having a brown fluid because of the degenerated products of the blood. Although it is a tumor which is having brown fluid, it is not brown tumor. Brown tumor is hyperparathyroid.
Right, sir.
All right. So, rest of the things, how to differentiate it with on the basis of the appearance on the X-rays. Sir is going to explain it to you that we are keeping prototype as a GCT and we are comparing GCT with these kind of
ABC. So, whenever a question of GCT is asked, an ABC is always given the question. Always given in the option. Okay, so remember these 2 things that you have to differentiate between the 2, and very simple point, just look at the growth plate and the age. Okay, if age is given to you in the question, less than 20-year-old, and the location, it is a metaphyseal location. Okay, so we are talking about age, we are talking about location. Okay, if age is young child, it is less than 20 years, or a skeletally immature patient, and the location is metaphysis, so it is an aneurysmal bone cyst, as simple as that. ठीक है, both of them are benign, so they will not cross the cortical breach, they will not erode the bone, there won't be any soft tissue, or there won't be any aggressive periosteal reaction. But you don't have to remember any of this. Just remember 2 points: age and the location of the tumor. Both of them are lytic lesions. If it is a metaphyseal lesion in a young patient, it is ABC. If it is an epiphyseal lesion in an skeletally mature child, it is a giant cell tumor.
One more thing, sir, like if I'm not wrong, that GCT lesions are called by the name of sobable appearance and aneurysmal bone cells by honeycomb appearance. But frankly, we don't go the way, like for the purpose of identification, we don't try to correlate it with a sobable.
Right, sir, right, sir. Very well said, sir. Very important point also for you to remember, because in today's era of questions that are coming, they won't mention honeycomb or sobable appearance in the question. They'll directly give you an X-ray. तो आपके ऊपर है to identify whether it is a sobable or it is a honeycomb. Okay, but remember the characteristic of the lesion, which are more favoring either a GCT or an aneurysmal bone cyst.
So you are saying that approach is more important,
right, sir?
Then correlating it with the sobable or honeycomb.
बिल्कुल sir.
That's what the approach for the identification is more important.
Right,
very
sir.
well said, sir. All right. Next differential diagnosis is fibrous dysplasia. In INI-CET examination this year also fibrous dysplasia was asked, and it is an important topic. It is a diaphysiometaphysal involvement. What happens in the pathophysiological mechanism of fibrous dysplasia is that immature cells, which are about to be differentiated into bone cells, so there is improper differentiation into a fibro-osseous cell, as a result of which the bone is not bone, it is a fibrous, and it's a mixture of fibrous tissue and a bone, as a result of which that bone is not going to have the strength which is required in that particular bone. So there are going to be morphological changes when it is used, and particularly femur is the most common site of the bone which is affected. So because of the weight bearing, there are going to be changes relatively. Yes, two very important tumors which are found to be associated with this polyostotic fibrous dysplasia. One is McCune-Albright syndrome. All of you must be aware of this. McCune-Albright syndrome, one feature is polyostotic fibrous dysplasia. The another feature is the Café-Eulé spot. The Café-Eulé spot, the two differentials, as far as orthopedic is concerned, sir. We are aware of two differentials for Café-Eulé spot. One is neurofibromatosis type 1, and the other one is McCune-Albright syndrome.
Right, sir.
Now, in McCune-Albright syndrome, there are regular borders, while in case of neurofibromatosis type 1, they are having regular borders. That is the difference we tend to know. And the third one is precocious puberty. Earlier appearance of secondary sexual characteristics in case of females. That is McCune-Albright syndrome. And soft tissue myxoma is simply the polyostotic fibrous dysplasia, as well as soft tissue myxomas. All right. So these are the two tumors which are extremely important, because so this year the question was asked. They gave us the features of this polyostotic fibrous dysplasia, and they also given McCune-Albright syndrome related features, like there is a skin lesion in the form of a Café-Eulé spot. All right. So hopefully you understood what are the very important facts related to this particular topic. Now, sir is going to explain you about how to identify it on the X-rays.
Yeah, so first remember, the fibrous dysplasia is a diaphyseal lesion. Okay, it's a diaphyseal lesion and it is not a tumor. Okay, so fibrous dysplasia there are no malignant cells per se. It is, as the sir said, that the progenitor cells do not differentiate into osteoid, they differentiate into osteofibrous cells. So there is deformity of the bone, and the abnormal white colored bone is replaced by ground glass. Okay, so remember, fibrous tissue in the bones, how will it appear? It will appear like ground glassing. Okay, and this is the buzzword which is sometimes given to you in the question also. They'll give you a CT sometimes of the head, and in craniofacial fibrous dysplasia are also very common, especially in polyostotic types. So you will see the ground glassing of the bone first. Since the bone is abnormal, it is tilted, it is deformed, so the femur, which is the most common site of FD, gives a Shepherd crook deformity. Okay, the Shepherd की जो डंडी होती है, that is called as a Shepherd crook, and it is in the shape of like this, so that's why it is called as a Shepherd crook deformity.
Very specific. Like Shepherd crook deformity, whenever you see blindly, you can go with the answer for fibrous dysplasia.
So remember, ground glassing and typical deformities of the bone, especially Shepherd crook deformity in cases of femur, favors of fibrous dysplasia. Okay. Sir.
If anyone is more interested in knowing, like, this is the weight bearing axis, all right, and if this is the compressive cortex, the inner one is always under compression, the outer one is tensile cortex, distraction. So because this bone is having less strength of bearing weight of the individual, this compressive cortex collapses, as a result of which there is a conversion into a Shepherd-Crook kind of a deformity.
Right.
All right. So this is specifically, you can answer this question very easily. Now, another very important differential is that of enchondroma. These are the kind of the tumors which are in trend today. The examiner is this way or that way asking these kind of the questions. Like, it's again a metaphyseal tumor, but what is more important is that it involves the smaller bones in hand, like phalanges and metacarpals are the most common sites to be affected by this tumor. And this question was asked in 2017 with a language like most common tumor of the hand, and majority of the students, they have marked the answer as enchondroma, although they were non-specifically asking the question like, what is the most common tumor of the hand? Squamous cell carcinoma was the answer for that question. All right. In case, so read the language carefully, read the language of the question carefully. Most common tumor of the small bones in hand, the answer would have been enchondroma. All right. Now, very important two syndromes. One is Ollier disease, other one is Maffucci syndrome. Ollier disease is simply multiple enchondromatosis, like multiple enchondroma lesion. All right. Ollier disease. And the possibility of malignant transformation for this Ollier disease is as high as 20%. 20% are the possibilities that this lesion might turn into a malignancy. Another one is Maffucci syndrome, where there is multiple enchondromatosis, one of the component, but it is also associated with cutaneous hemangioma. All right, cutaneous hemangioma. And what is the possibility of this thing to get converted into a malignancy? The malignant transformation, the possibility is as high as 40%.
Right, sir.
So, sir, this becomes the base of the question asked. Like, which of the following lesion has got the highest propensity or tendency to get converted into a malignancy? And the options provided were multiple enchondromatosis and cutaneous hemangioma, multiple enchondromatosis, multiple GCT lesions, likewise were the options provided. So, answer for that question is Maffucci syndrome.
Right, sir.
All right.
And just an important pointer to identify an enchondroma, as sir rightly said, small bones of the hands and also the feet, even metatarsals, phalanges of the feet can also be involved in enchondromas. And another pointer, that it is an intramedullary lesion. Okay, so in the center of the bone you will see the lesion, and it eats out the bone from within. So there is end osteal scalloping. Sometimes you can be given this buzzword in the question, end osteal scalloping, and when this is given, you favor an enchondroma. Okay, and enchondroma usually transform, if they transfer into malignant transformation, usually a chondrosarcoma is a malignant transformation of an enchondroma. Right, sir?
Exactly, sir. If somebody asks, like, what is the most common malignant tumor of the small bones in hand, then it's going to be chondrosarcoma. Because enchondroma is a benign tumor, which is obviously the most. Hopefully, sir, we have discussed, means related to the question. Now, if we go back to the question, now it becomes much easier for us to identify, because sir has very well explained that how to differentiate it on the basis of the X-rays only provided. And with a small hint of the age given to you, you can make up or you can come up with the diagnosis. So among the four options, your answer for that particular question is the giant cell tumor. All right. Sir, it is also important to have a discussion on
few other important bone tumors, since we are on the topic of bone tumors.
Exactly, sir.
So we'll just cover two important tumors. First one is an Ewing sarcoma. So what are the pointers favoring an Ewing sarcoma in a question? First is age. Okay, so usually young patients, typically less than 10. So both osteosarcoma and Ewing sarcoma affects children, but typically age that is given to you in an osteosarcoma is between a 10 to 20-year-old child, whereas Ewing sarcoma affects much younger population, so less than 10-year-old. And in cases of a long bone, you see that it affects the diaphysis. So in cases of Ewing sarcoma, if we are talking about long bones, then it will affect the diaphysis. Okay, it will also be a lytic lesion and a typical periosteal reaction it shows. Okay, periosteal reaction is a multilamellated periosteal reaction, also known as an onion skin periosteal reaction. So if this is the tumor, you see that these multilamellated periosteal reactions affecting the diaphysis of the long bones favors an Ewing sarcoma. And the clinical profile would be that of a patient coming to you with fever, raised leukocytosis.
Exactly.
And you will be given an X-ray. So it is sometimes very difficult to differentiate between the chronic osteomyelitis, which is a very important DD of an Ewing sarcoma, because both of them affects young children and have a similar clinical profile. Okay, but in cases of chronic osteomyelitis, what is typically seen on bones is a sequestrum. Okay, typically seen on a bone is a sequestrum. And Ewing sarcoma has a soft tissue. So you do an MRI. Okay, so in an MRI, you will see exuberant soft tissue in cases of an Ewing sarcoma. In chronic osteomyelitis, you will see sequestrum, that is a dead bone. Okay, that is how you differentiate between the two. And these are the important pointers for an Ewing sarcoma. Sir, anything else you want to add?
You know, the basic pathophysiological mechanism behind both these two conditions like osteomyelitis and Ewing sarcoma is that the bone tries to limit the expansion of the disease. All right, and how bone will try to limit the expansion? By activation of this periosteum, because there will be a secondary activation of the periosteum. So bone, if this is the tumor, like, and it tries to spread, so periosteum will try to encase, it will try to limit the expansion by the creation of the bone by the periosteal reaction. But because the tumor is a malignant type, it will breach this wall again. So there will be another attempt taken by the periosteum in order to contain it. That gives it a look of a onion peel appearance in order to contain it. All right, as sir very well explained, like, you know, differentiation in between the osteomyelitis and Ewing sarcoma is very difficult because of the age, because of the clinical features, because of the presentation, even because of the X-ray findings, which are relatively same.
Both of them affect diaphysis.
Exactly. So Ewing sarcoma is very important, and you know, this is the tumor which melts on radiotherapy. But despite that, primary Ewing sarcoma, radiotherapy is avoided in the management.
Chemotherapy is the mainstay.
Yeah, because if the question is asked, like, you know, sir, everyone is aware, like, Ewing sarcoma responds dramatically to radiotherapy. But it does not mean that radiotherapy is the management of choice for Ewing sarcoma, right? Another very important tumor which is in trend today is just on the basis of identification. All right, they will be asking that what is the name of this tumor. It's going to be a spot diagnostic question, because you can very clearly see there is a tumor which is originating or outpouching from the metaphyseal region of the bone, and the name of this tumor is osteochondroma. All right, osteochondroma or exostosis. So osteochondroma basically is an outpouching tumor from the metaphyseal region of the long bone, and it is also covered by the cartilaginous cap. So there are only 2 points that you need to remember. Point number 1 is identification, which is very simple identification. And point number 2, that, you know, the medullary canal of both these two, that means the parent bone and that of osteochondroma, are one. There is no break in between the two.
Right, sir.
All right, there will be a cortical continuity in between the two.
Right, sir.
If there is a break, then it is not osteochondroma.
Right, sir.
All right, that is any other lesion. So these are the 2 facts that you need to remember. Otherwise, for the purpose of identification, we are expecting that they might ask osteochondroma at any point of given time.
And osteochondroma is usually easier to identify. You will see a lesion continuous with the main bone and it grows away from the joint. Okay, so if there is an osteochondroma of the tibia, so it will typically be like this.
Yeah.
Okay, if it's that of a fibula, it will typically be like this. It grows away from the joint. Okay.
So sir, enough we have discussed about, like, it's a revision session.
Let's move on to the next question.
All right. So next question is that, you know, because the questions are getting more and more clinical. Imagine a patient coming to you with the osteomyelitis, infective condition. All right. They gave you entire clinical picture in which they have already suggested that the patient is suffering from osteomyelitis. All right. Now you have to diagnose this condition without invasive investigation. Now we are left with 2 options. One is ultrasonography, other one is MRI. Now the thing is that MRI is considered to be the investigation of choice, but if the question is that what next you will do, then you have to decide whether should I go for USG or should I go for MRI. What are the advantages which are provided by the USG over MRI, or what are the advantages of MRI which are provided over the USG? It is a very important topic. You know, if you are confused, then the examiner will try to take the advantage of that confusion.
Yeah, because examiner know that student also know that investigation of choice for acute osteomyelitis is an MRI. So he knows that the student will mark the next line of investigation as MRI. But especially in children, the patient, the question is asking septic arthritis or acute osteomyelitis in children, and you have both ultrasound and MRI. So nowadays, what we typically have read in ultrasound is that for bone evaluation, ultrasound is not used, either an X-ray or a CT is used, but especially in cases of acute osteomyelitis, what typically happens that in an early stage of acute osteomyelitis, even on an X-ray, the bone lesions are not seen. What you typically see are soft tissue changes. Okay?
Exactly.
So, for soft tissue changes picking up, ultrasound is a very good investigation. And in children, you have the advantage that their skin is thin, their soft tissue is thin. So, an ultrasound evaluation can very well evaluate the soft tissues also. So, remember, an ultrasound will be the next investigation in case of a suspected acute osteomyelitis because A, it evaluates the soft tissues. And what do you see in cases of acute osteomyelitis in soft tissues? You see soft tissue swelling. Okay, you see soft tissue swelling, you see soft tissue edema, and sometimes if there is an infection, fluid also accumulates in soft tissue. So you will see fluid. Second, what you see periosteum. Periosteum evaluation can also be done on ultrasound. And in cases of periosteum here, so this is very well seen on this image as well. You see that the periosteum is lifted up and there is a subperiosteal fluid, subperiosteal abscess. These can also be very well picked up on ultrasound. And even if there are cortical erosions, so they can also be seen as irregularity when they occur. Okay, so when does an X-ray findings appear in cases of an acute osteomyelitis? Remember, by day 10 to day 14. But before that, if a patient comes with a typical clinical profile, an X-ray would be normal. And in fact, it is the ultrasound which can show you the changes sometimes. And what are the changes? I just discussed: soft tissue swellings, edema, abscesses, subperiosteal fluid, subperiosteal abscesses. And suppose the ultrasound is indeterminate, and in such cases an ultrasound is negative. Let's assume ultrasound is negative. Then you would go for an MRI. Now, what are the disadvantages of MRI? So MRI, first of all, is an expensive modality. Exactly. It is not available everywhere.
Exactly, sir.
It is a longer investigation. It takes 1 hour to perform a complete MRI scan. And especially in children, you have the problem of sedation. Children move a lot. They don't lie still. You have to sedate them. So next line of investigations cannot be MRI because it is not feasible at a lot of times. So ultrasound, if it is able to give you the same information, will be the next line of investigation. And that is why in such case, the answer would be in ultrasound.
Exactly, sir. So thank you so much, sir. Exactly what happens is, as an orthopedic surgeon, you are suspecting a child could be suffering from infection in or around the joint. Now, 2 points you need to know whether the joint involvement is there or not. And you want to get the investigation done as early as possible. And you don't want the patient to spend too much. All right. So on those basis, you are getting the ultrasonography. It should be the next investigation, particularly in the child. You know, for you, these are going to be your questions subsequently.
And these are the confusing options because हमने तो पढ़ा है कि acute osteomyelitis में investigation of choice is MRI, but यहाँ पर तो option में ultrasound भी दे रखा है. Depending upon the language of the question, what the question is asking, the answer changes.
Exactly, sir. So next investigation is very well explained, sir. I mean, this was a huge confusion, and possibly everyone is aware of it now. All right. Next question is: 24-year-old came to OPD with the pain of limping, with the history of limping and pain for the last 9 months. There is a long protracted history. Details revealed that he took the management for a skin allergy. Now, one of the thing is that clinical feature in the form of a history is provided. Detailed history revealed that he took management for the skin allergy. One of the etiology is provided for 1 year. So he took the management for his skin allergy 1 year. On examination, ASIS, that means anterior superior iliac spine, both of them level is equal. But there is a limitation of abduction and internal rotation of the left hip. His ESR is found to be 8 millimeters for the first hour. Like, it is normal because if it is beyond 10, it is found to be elevated for the first hour. What is the most likely diagnosis? Now, there are again, these are again the options in the form of a differential that we are about to rule out. Right. In the form of a differentials. So, quickly, we are not jumping to the answer. We are going to talk about the individual differentials which are provided in the option. And one of the very important fact is to differentiate it between the x-rays of tuberculosis of the hip joint and osteonecrosis head of the femur. It is essentially important. So sir is going to explain that how to differentiate in between the two and what are the key points of so that you can immediately identify that this is the x-ray, possibly that of the tumor.
So since
avian or tuberculosis.
Right, sir. So since this was a 24-year-old male, we can safely assume that the options transient synovitis and septic arthritis are less likely.
Less likely.
They can still occur, but they're less likely because they're typically diseases of the children. So we are left with two options, TB hip and avian. And this is how also you should attempt a question. Your main aim should not be to rule in the option, but to rule out. Because a lot of times you will not be able to know all the options that are given in the question. You can rule out some options. So in this case, you are left with two choices. And since you have two choices, you have to attempt this question. Now, two important difference, just two words I will say, which will help you remember the question, that in TB hip, you look at the bone mineralization and you look at joint space. Okay, TB hip is an infectious condition, long-standing infectious condition with secondary inflammation. So there will be osteopenia. So in TB hip, what will we remember? We'll remember periarticular osteopenia. We'll remember periarticular osteopenia. And second thing what we'll remember is reduced joint space. Reduced joint space. And third thing that we'll remember are erosions. Typically subchondral or periarticular erosions. Now, in the first X-ray, what do we see? We see that there is periarticular osteopenia affecting both the acetabular and the femoral aspect of the hip joint. And we see, as compared to the left side, the right side of the hip has reduced joint space, and also the femoral head is irregular. It is irregular. So these are the three findings of TB hip. And you also know this by the triad of Semester triad. But it is important to see the findings, that to remember the triad per se. What have we learned? We have learned reduced joint space and periarticular osteopenia early in the disease, as compared to osteonecrosis of head of femur. Earlier it was called AVN. What we see, that the joint space involvement is a late feature. It is a late feature when secondary osteoarthritis develops. So even though the head is so deformed, it is so destructed, the joint space is not so severely affected. And you see that the acetabular end, acetabular surface is not so much involved as the femoral surface. So it is an asymmetric involvement. So the femoral head per se is more involved. The joint space is maintained still in this disease, and the head has sclerosis. तो कितना अलग अलग है ना, बिल्कुल ही ऑपोजिट है टीबी हिप के. टीबी हिप में देयर वाज ऑस्टियोपेनिया, इन एवियन देयर इज स्क्लेरोसिस. इन टीबी हिप जॉइंट स्पेस वाज रिड्यूस्ड, एवियन में जॉइंट स्पेस इज मेंटेन्ड इवन टिल द लेटर स्टेज, एंड द डिजीज इज लिमिटेड till the femoral side. Sir, anything else you want to add?
Exactly, like there will be flattening of the head of the femur,
Right,
which is
sir.
evident in case of avascular or osteonecrosis head of the femur, because head of the femur is a weight bearing surface, you know, and if the head of the femur becomes weak, then it won't be able to bear weight of the individual, and under the influence of that weight it starts getting collapsed. So collapsing will be there, sir. And obviously, as sir has very well explained, that these are the stark differences in between the tuberculosis and osteonecrosis. And in osteonecrosis, head of the femur, you know, joint space reduction is the last finding to happen because of secondary osteoarthritis. So hopefully everyone is aware now how to differentiate in between the two, sir.
Yes, just few named signs in cases of osteonecrosis, I would say. So one sign that you have read in classes is the crescent sign. So just for the sake of completion, we'll write crescent sign in cases of osteonecrosis. And yeah, remember which is the area of the head that is involved. So the superior articular surface of the head, this area, typically 10 o'clock to 2 o'clock area. This is the area of the head, femoral head, that is involved in AVN. So obviously you will see flattening of head here. You will see flattening of head here because, as sir mentioned, this is the weight bearing area of the hip joint. So there will be flattening of the head here. And what is this crescent sign? This crescent sign is, usually this is not seen here, but in cases of an AVN, if this is the head, if this is the head of the femur, there is a subchondral fracture. Remember the term buzzword, subchondral fracture is associated with AVN of hip, and there is this linear hypointense line on the X-ray that you see, which tells you that it is a subchondral fracture.
Exactly.
And this is known as a crescent sign.
Exactly.
It
It is an early feature.
It is an early feature even before the collapse occurs.
Before the collapse, yes. It's a feature of a pre-collapse stage of osteonecrosis.
Yes, sir.
Exactly. Now, after having discussion of the X-rays, means on the basis of the identification of the X-ray, now back to the question, like what could be the differences provided to you in the question itself? Like if what goes in favor of tuberculosis is a relatively shorter history, because it is a progressive kind of a disease, relatively rapidly progressive. So the history is going to be provided in weeks to months, like 2 months, 3 months. But in case of AVN, it's going to be a long history, like 9 months, 1 year. All right. Pain and limping is going to be the same in case of both of them, but there will be more pain and more limping earlier in the course of disease. It will be earlier in the course of disease in case of tuberculosis, while it will be relatively late and progressive in case of osteonecrosis head of the femur. Now, second is associated constitutional. As you know, that tuberculosis, the patient will look sick. You know, there will be weight loss, there will be loss of appetite, there will be a positive history also. So all these features. And yes, a night cry. You know, the patient will be experiencing more pain at the night while he is relaxing in comparison to the movements. But in case of avascular necrosis or osteonecrosis, a significant etiology will always be provided. One of the most important etiological factor is alcoholism. You know, we are not going to discuss the entire etiology over here, which are likely to be provided in your question. One is alcoholism. Second is smoking. And more importantly is the injudicious use of steroids in the form of drugs more commonly. You know, it is a very, very common phenomena. And we have just now recovered ourselves from COVID.
Yes, sir.
And in COVID, there were, you know, too much of the steroids
that
provided.
were given. Yes, sir.
So we are having the incidences on a regular basis. The incidence is on a rise. That the patient is suffering from osteonecrosis. So this also could be provided to you. The patient had a history of a COVID, and there are several of the drugs which are also responsible for this. Like apart from steroids, there could be antiretroviral drugs. So these are the etiology at least that you have to remember. Apart from this, you already know like Gaucher disease, then sickle cell anemia, the Kaizen disease, deep sea diving, all those things can also lead to it. But the etiology will always be provided to you in case of avians.
Especially in an adult.
Yeah. Then as far as clinical features are concerned, in case of tuberculosis, it's going to be stage specific. Like stage of synovitis, the earlier stage, the limb is going to be kept in flexion, abduction, and external rotation. All right. And in case of arthritis, once there is an involvement of the joint, like early arthritis, late arthritis, there's going to be flexion, adduction, and internal rotation. But here in this case, the patient is going to always have these clinical features, like there will be limitation of abduction and internal rotation. And these are considered to be the cardinal examination finding for osteonecrosis head of the femur. Now, based on these two facts, if we go back to the question, like 24-year-old male came to OPD with the history of limping and pain. So it remains common in almost every other differential. Since 9 months, now there is a long history which is provided. Detail revealed he took management for a skin allergy. Now skin allergy management possibly from steroids, sir. Right? 1 year history is there for the management. Now there is a limitation of abduction and internal rotation. By the time you reach this line, you already have made your diagnosis. And ESR is found to be 8 millimeters, which is within normal limits. Now, what is the most likely diagnosis? So, tuberculosis is ruled out. Septic arthritis is obviously ruled out. Transient synovitis is ruled out. You are left with osteonecrosis. So, these are going to be your questions in future, and how to identify a very closely related condition based on the X-ray findings and the questions provided.
So, AVN is an important topic for exam.
Yes, AVN is really an important topic for exam. And because the incidence is on a continuous rise, so possibility you are going to get this question is too high. All right. So next is, like sir has told, you know, that previously the condition was called as AVN.
Yeah.
Today it is called as osteonecrosis. You know, there is a reason for this change in the terminology. Like avascular necrosis, you are imparting the etiology in the, or you are fixing the etiology in the outcome of the disease. No, don't fix it with the etiology. Etiology could be anything other than
vascular cause.
Vascular cause. So osteonecrosis is eventually what we are getting.
Yes, yes.
So that is the reason why there is a change in the terminology from avascular necrosis to osteonecrosis. So If a question is asked, it will be asked in the form of osteonecrosis.
Osteonecrosis, because the latest terminology now is osteonecrosis of head of femur. Yeah, so remember this term.
Olaf, you are asking why night cries. Sir, there are questions also coming. Like, Olaf, you are asking why night cries. You know, why the patient is experiencing more pain at rest, because by the time he is mobile, all the movements are fixed by the spasm of the muscles around. And when the patient take rest, there will be a loss of spasm. When there will be a loss of spasm, there will be a permissible movement allowed at the level of the joint. And this movement will cause pain in case of early arthritic stage. So that is why the patient experience more pain at night as in comparison to the other. What the medications for skin, sir? So these are all.
a lot of skin medication can be given, but I think skin allergy ke liye lot of people prescribe steroids. So that is what is the interest in the question.
All right, sir. One more question with that we can take, like soft tissue shadows. Like what, you know, we were talking about that USG for acute osteomyelitis.
Yes, sir. Yes, sir.
So somebody has asked, like, what day, like in case of X-rays, the features are going to be evident on the second week, like 10 to 14 days.
So the bone changes, yes. So the bone changes are evident later. So that I told on day 10 to day 14. But on soft tissues, yes, the soft tissue changes occur much earlier and they're better picked up on ultrasound. But even on X-rays, what you see in cases of osteomyelitis is loss of fat planes. Because there is soft tissue edema, there is muscle edema, so the fat planes get obliterated even earlier than the bone changes. So you can see them on even on the first week as well.
Exactly, sir. Sir, we will take up the question.
Yes, sir. Yes,
like
sir.
Now, first of all, before we even talk about this question, what is the importance of this question is that, you know, knee pain with joint arthropathies, because knee is very commonly affected in any of the joint arthropathy or the joint diseases. Like, what could be the differential and how to rule them out? Because the clinical features are so much overlapping again. We cannot easily rule out the other condition. So that is the essence of this question asked. 78-year-old female, the age is very important. Came to OPD with the complaint of progressive pain, bilateral knee with the difficulty in sitting cross-legged and inability to squat. Pain increases on walk. Means it is related to activity. You know, once there is more activity, there will be more pain. It increases. And is getting difficult to walk without support. So progressive deformity is there, progressive pain is there, and it is getting more and more difficult for the patient to walk on herself. Examination revealed bilateral varus deformity. All of you know the mediolateral deformities of the joint, in which the joint is kept extended. It could be varus or valgus. So deformity with the medial joint line tenderness and crepitus is present. No deformity in the hands. Obviously, they have mentioned specifically that there is no deformity observed in the hand, because when such a patient will come to you, you will examine the entire individual, and one of the specific findings that you will look for is there any swelling, is there any deformity in the wrist joint or in the hands, in order to rule out certain other conditions. So X-rays are done. So sir, before we even talk about this condition, but like all the features we have already discussed, it is important to identify what all is provided to you in the X-ray, and sir is going to explain it.
Yes, sir. So what we are typically seeing is that a large joint arthritis which increases on walking. So it is a non-inflammatory arthritis affecting the large joints. Okay, so this terminology should be clear because it rules out a lot of things. So typically a non-inflammatory pathology will have pain which increases on activity, as sir said. So we are not dealing with the typically inflammatory pain. And amongst these questions, now let us see the X-ray findings. So here we see that the joint space is narrowed. Okay, this is an evident finding that if this is the joint line, the joint space is narrowed here, and it is narrowed more on the medial compartment as compared to the lateral compartment. Now the medial compartment of the knee is the weight bearing compartment in cases of knee, and so osteoarthritis, I think most of you have made the diagnosis of osteoarthritis, involves the weight-bearing part of the knee. So the medial compartment is affected much more than the lateral compartment in cases of knee. And also one of the pointers which favor a non-inflammatory or a degenerative arthritis will be subchondral sclerosis, subchondral cyst, asymmetric joint space narrowing. Versus if it is a inflammatory arthritis, so inflammatory arthritis involves the synovium, and the synovium runs along the entire joint. So it will be in cases of inflammatory arthritis, there will be symmetric joint space narrowing and there will be periarticular osteopenia because there is inflammation. Periarticular osteopenia. But what we are seeing in this case is an asymmetric joint involvement, medial compartment more than lateral, and there is subchondral sclerosis. So even on these two bases, you can easily tell that it is a non-inflammatory or a degenerative kind of arthritis. So the answer here will be osteoarthritis, primary osteoarthritis of knee. And the elderly patient typical clinical profile also tells you the same, sir.
Thank you so much, sir, because it is very, very important to distinguish the clinical feature which is overlapping.
Right, sir.
So we are provided with several options, and it is also important to rule out the other options. Like one is the rheumatoid arthritis. So how rheumatoid arthritis question is going to be provided? Like we see this is a clear-cut difference in between rheumatoid arthritis and the osteoarthritis. Clinical features which could be provided, like age of onset is very important. It is relatively younger in case of rheumatoid arthritis, while it is elderly in case of primary osteoarthritis. So more than 50, 30 to 50 depends. Now the pain will be worse during or after activity, as it has been already stated in the question, but here the pain is going to be worse in the morning. All right. In case of, as far as the stiffness is concerned, it will be worse during or after activity again, while in case of rheumatoid arthritis, it is always related to rest, more common in rest. Joint characteristic will be hard and bony, but here in the other case, it is going to be softer, it will be warmer, and it will be tender also in comparison to the primary osteoarthritis, degenerative arthritis. Now the joints which are affected, distal interphalangeal joint, the carpometacarpal joint, all right. So and the knee, the joint which is relatively spared in case of osteoarthritis in hand is the metacarpophalangeal joint.
Right, sir.
It is not primarily very commonly affected, while the joint which is spared in this case of rheumatoid arthritis, a joint which is spared which is not very commonly involved is the distal interphalangeal joint.
Very important point.
So in case of osteoarthritis, it is the metacarpophalangeal joint which is spared, while in case of rheumatoid arthritis, it is a distal interphalangeal joint which is spared. Now, as far as lab findings are concerned, you are not going to find any abnormality related to the disease. Like normal rheumatoid factor, there will be no normal anti-CCP. It is not an inflammatory condition, so ESR and CRP are going to be normal. But here, there's going to be a positivity identified in case of RA factor as well as in case of anti-CCP with the elevated ESR and C-reactive proteins level. As far as associated signs are concerned, these are going to be one-liners. Like they are not going to be provided in the form of a long question.
Right.
Like Herbidin and the Bouchard nodules. Like Bouchard nodules is the involvement of the proximal interphalangeal joint in the hand, while the Herbidin is the involvement of the distal interphalangeal joint in case of hand. And these ulnar deviation, you see, not exactly ulnar deviation, it could be ulnar or radial deviation. Depends.
Yes, sir. Anything.
All right. Botonier deformity, how to identify a swan neck. One thing is very clear that has to be ascertained is that swan neck deformity is the extension of the proximal interphalangeal joint. All right. While botonier deformity is the flexion of proximal interphalangeal joint. We tried to designate the swan neck deformity as like it is the extension of the proximal interphalangeal and flexion of distal interphalangeal. So it gives us a wrong impression that the distal interphalangeal joint is primarily affected by rheumatoid arthritis. Exactly not.
Yeah.
It is a secondary involvement of the distal interphalangeal joint which pulls it into flexion because of the hyperextension which is happening at the proximal interphalangeal joint.
Right, sir. Right.
Exactly opposite is the buttonhole deformity. It is a French word like botonier deformity. It is a buttonholing where there is a opening of the ligaments on the extensor aspect, where there will be a flexion of the proximal interphalangeal joint. Secondary to that, there will be a hyperextension of
DIP.
The distal interphalangeal.
In both the cases, PIP is predominant.
PIP is primarily affected. There will be a secondary involvement of the distal interphalangeal joint in case of botonier and the swan neck deformities respectively. Hopefully, you get the essence that how the questions are going to be formulated if they are asking about rheumatoid or if they are asking about the primary osteoarthritic abnormalities. Sir, it is also important, like you have very well explained about the X-ray findings which goes in the favor of osteoarthritis primarily affecting.
And we'll just
how the X-ray findings of the rheumatoid arthritis are going to be identified.
Yeah, so we talked about how X-ray of osteo looked. We'll just see how the X-ray findings of an RA look. So RA, what we typically say, involves the small joints, but yes, large joints can also be involved. So here we are looking of RA involvement. In this second pic, we are looking at rheumatoid arthritis involvement of a large joint, that is knee. And as I told you earlier, two important findings, that there is symmetrical involvement of both the medial and the lateral compartment of the knee. So even the medial compartment has reduced joint space, the lateral compartment has also reduced joint space, and there is periarticular osteopenia in both the bones. So important point to remember, symmetrical joint space, narrowing in cases of rheumatoid arthritis, while in cases of osteoarthritis there is asymmetric.
Exactly, very important point for the purpose of identification, and it will be made evident. You know, if the examiner clearly wants you to mark the correct answer, then he'll give this kind of the scenario in the X-rays.
Right, sir.
Very good. Means hopefully you get the answer, because as a practicing orthopedic surgeon, it is also difficult for us to identify it on the X-rays only.
Right,
you know?
right.
Until and unless we don't correlate it with the clinical features,
findings,
we can't make the diagnosis out just on the basis of the X-ray. So it is extremely helpful for me also.
And in fact, osteophytes, sometimes people see osteophytes and label them as degenerative or rheumatoid. But remember, in RA also, even advanced stages, you can see secondary osteophytes because of secondary degeneration. But involvement of joint space, which part of the joint is more involved, remember, weight bearing areas in case of degenerative, so medial compartment of knee more involved.
Very well explained, sir. As far as another differential is concerned, pseudo-gout.
Right, sir.
You know, practically, based on the clinical features only, it is almost impossible to distinguish the primary osteoarthritis and a pseudo-gout. You know, because both of them are a degenerative arthropathy of the joint, of the large joint, and goes in the favor of elderly, because it is more commonly seen in the elderly. Until and unless you go for the biochemical analysis of the fluid that you have aspirated, which reveals the calcium pyrophosphate. This is calcium pyrophosphate dihydrate crystals. Alright, that is a diagnostic criteria for the pseudo-gout. So in an examination, sir, I think it is highly unlikely that the examiner will ask about pseudo-gout as the answer, until and unless he don't mention this calcium pyrophosphate dihydrate crystals or the characteristic of these crystals in the question itself.
Right, sir. Right, sir. The only thing on X-ray that sometimes is seen is chondrocalcinosis. So chondrocalcinosis is calcification of the chondral cartilage. So in the knee, sometimes the menisci, they get calcified, and they are sometimes seen on X-ray, but not very commonly common findings. So it is very difficult to see mostly on X-rays.
Exactly, sir. So hopefully we have covered this question also.
Right, sir. So I think arthritis ka kafi part we have discussed in the form of question.
The difficult part was like identification of the primary osteoarthritis and how to differentiate it from rheumatoid arthritis on the X-rays. All right, sir. Next question is that of about injury and the identification of that injury on the MRI. You know, this is also a confusion. Again, very confusing aspect. Like many of the time, as a student, you think, or we think is that, you know, MRI is the investigation of choice for these kind of the traumas, and what is the exact timing in order to diagnose it. The question is pertained or related to acute or immediate ACL injuries. Which of the following is incorrect? Means they are asking about the approach, that which of the following shouldn't be your approach in the management of a ACL patient. Point number 1, it is a result of a valgus of the knee in external rotation and flexion. This is the mechanism, and yes, this is the mechanism for the anterior cruciate ligament injury, where there will be an anterior cruciate ligament which is forced to an extent when it is in the valgus with the external rotation and flexion, it is rotated, all right, externally rotated. Next, the Lachman test for the provisional diagnosis. Yes, there are 2 tests which are available in order to diagnose the condition provisionally. But you know, out of these 2 tests which are very commonly performed, Lachman is given a priority in acute injuries.
Okay.
All right, in comparison to the anterior drawer test. Now the difference is very clearly evident. You know, ACL, the function is to prevent the anterior translation of tibia on femur. It prevents it. If ACL is completely ruptured, then there is nothing left. You can easily appreciate the anterior translation of the tibia on femur. This is appreciated by Lachman and anterior drawer test. In Lachman test, the knee is bent to 20 to 30 degrees. So knee flexion is just 20 to 30 degree. While anterior draw test, the knee flexion is 90 degrees. Now, why this thing is avoided in acute injuries? Because by flexing the knee joint to 90 degree, you are further compromising the space, the knee joint space. And because there is too much of the collection of the blood inside the knee joint already, like hemarthrosis, so the condition would be extremely painful for the patient.
Okay, yes, sir.
All right. So in favor of the patient, this test is avoided in acute injuries. But Lachman test, what you are doing, you are just flexing it to 20 to 30 degree. And it certainly to some extent increases the carrying capacity of the knee joint. Although it is not going to be a comfortable test for the patient, but it is having less discomfort in comparison to the anterior draw test. And that is why it is a preferable test for acute injuries. It is preferred in acute injuries, the Lachman test. All right. So hopefully the second option is also true. That Lachman test for the provisional diagnosis. Yes, you will try to do this. Third one is the immediate MRI. Now this is a point that sir is going to explain it to you, because now you certainly want to know the diagnosis. All right. You are having a patient who has sustained injury to his knee. You have provisionally diagnosed that possibly it is anterior cruciate ligament injury because it is related to sports. Now you have to make this diagnosis certain. And for that, all of you are aware of the fact that anterior, for these ACL injuries, the investigation of choice is the MRI.
MRI. And this is what we get also clinical requisitions. If a patient has an injury, sports injury 2 days back, and we are suspecting an ACL injury, kindly give date for MRI or kindly do urgent MRI. And what we say to that patient is, please come after 4 weeks.
Exactly.
And patient says, सर मेरी इंजरी हुई है, ऑर्थोपेडिशियन ने बोला है सर आपका ACL टूट गया है, आप मेरा MRI क्यों नहीं कर रहे? हम बोलते हैं आपका MRI होगा 4 हफ्ते बाद, और ये ऑर्थोपेडिशियन को भी पता है, बस पेशेंट को नहीं पता होता. एंड ऐसा क्यों है? बिकॉज इन एक्यूट इंजरीज देयर इज अ लॉट ऑफ hemarthrosis, as sir rightly said, there is a lot of edema, and in that cases separating it from a tear becomes difficult, because in both tear and both edema you will see hyper intensity within the ACL. ठीक है. So we ask the patient कि जब edema settle हो जाए तब we'll see कि ACL कैसा लग रहा है, उसके अंदर fluid है कि नहीं. ठीक है. So first we'll see how does the ACL actually looks and how does the PCL actually looks. Where are they located? So as the name suggests, anterior cruciate ligament. So anterior ligament will be an ACL ligament. So for theoretical purposes, ACL arises from the inner aspect of the lateral femoral condyle and inserts on the anterior part of the intercondylar area. So ACL anterior part of tibia. ठीक है. The anterior and posterior is in relation to tibia only. Okay, so since this is the patella, so we know that this is anterior, this is posterior, and the ligament that is attaching on the anterior aspect of the tibia will be ACL. And this is anterior, this is patella, so this is anterior, this is posterior. The ligament that is attaching on the posterior aspect of the tibia, this will be PCL. This will be, PCL. Okay, so PCL arises from the inner surface of the medial femoral condyle and attaches on the posterior part of the tibia. Both ACL and PCL, because they are ligaments, they will be hypointense. They will be hypointense on MRI, be it any sequence T1, T2 or proton density. So if there is tear in the ACL, if there is tear in the PCL. So these are the normal ACL and PCL. If there is tear, there will be fluid signal within these ligaments. So how will that look? Here you see that there is loss of continuity within the ACL. The ACL is not seen to attach here. Here you were seeing that this is the complete ACL. Here you see that there is loss of continuity of the ACL. So this is an ACL tear. Whereas in this case, you see that the PCL is discontinuous. There is loss of continuity within the PCL. This is the fluid signal between that. So this is a PCL injury. And when is an MRI done for suspected ligamentous injury? Remember, after 1 month when an edema has subsided. Sir.
Very well explained, sir. Now, hopefully you have understood that immediately after injury, MRI is not going to be of any use.
Yes,
all right? Because it will impede the visualization. The hemarthrosis will impede the visualization. In order to get the correct diagnosis done, you have to wait. for that edema to get subsided. Exactly. So this, sir, is the answer for this question.
Right.
Like if they are asking about the incorrect statement, so this is the incorrect statement.
Right, sir.
But before marking the answer that is known, you have to rule out the other options
Right,
also.
sir.
Like knee brace is given, rest is asked, full weight bearing walk is allowed. Yes, it is allowed because you know it is not a weight bearing kind of a ligament. It is just a stability providing kind of a ligament, and you can ask the patient to bear weight based on its requirement, based on his or her requirement. But you have to fix the knee by provision of the external support in the form of a knee brace. So bed rest is not provided. Bed rest, the patient is not asked to go for the complete bed rest. Sir, also because this question is very, very commonly asked in the form of the attachments like ACL and PCL attachments on the knee joint or inside the knee joint. Both of them are intra-articular, you know, they are intracapsular ligaments. So, you know, ACL is originating from, as sir has very clearly said, that it is originating from the lateral femoral condyle, inner surface, all right? While PCL is originating from the medial femoral condyle, but the inner surface, all right? And the direction of the ACL is, you know, downward, forward and medial. So this is the direction of ACL, and exactly opposite is the direction for PCL. The moment that like when you project your hand in your pocket, that means downward, forward and medial. This is the direction of ACL.
Bilkul, sir.
So
Bilkul.
it will become much easier for. Remember, attachments of ACL are very, very important.
So it goes from here to here.
Yes.
This is ACL, and the PCL would go from here to here. Okay, as sir rightly mentioned, sir.
All right, sir. So I think we are done with this question.
Yes, sir.
It's again a very core clinical kind of a question. Like, all right. So next is the mother of a 6-year-old boy came with a complaint of limping observed in the gait for the last month. Now this is the observation of the mother. 6 years is the age which is provided, and it is important too. Like age is also important in this question in particular. All right. Now 8 months. Detailed history revealed that the child could be suffering from attention deficit hyperkinetic disorder, the ADHD. So there is a stereotypical picture of the child that might be discussed in future. On examination, there was no varus or valgus deformity in any knee. Like, because you know, if the child comes with limping, you have to examine the ankle joint, you have to examine the knee joint, and majority of the times, the reason for this limping in this age group is rickets. And they are found to be associated with the varus or the valgus abnormalities. So there is no varus valgus abnormality. Right-sided thigh had limitation of abduction and internal rotation. You know, once we are going to talk about this differential or the question, you will find that this is a key clinical finding mentioned on the basis of which you will mark the answer correctly. X-rays are done. What is the most probable diagnosis? Again, before jumping to the answer, let's evaluate each and everything which is provided in the question. Like in the form of the X-rays, sir is going to tell you that what are the specific findings in this particular X-ray, sir.
Okay, so first we see the normal joint. So at an eyeball, we know that the left hip is abnormal. So there is no doubt in this that the left hip, this is the left, this is the right in cases of X-ray. No confusion in this. This is the normal side. What we see here, we see that this is the epiphysis of the femur. This is the metaphysis, and this here is the growth plate. This here is the growth plate, and this is the joint. No confusion till now. What do we see on the left side? We see that the femoral epiphysis is small, destructed, and fragmented. Okay, so there is the primary pathology is in the femoral head, but the joint space is maintained. The joint space is maintained and in fact little widened. So the answer here will be, since it is an infant, it is an avascular osteonecrosis of femoral head. This we can see on head, this we can see on X-ray, and idiopathic osteonecrosis of femoral head epiphysis in children is known as Perthes disease.
All right.
So this is the answer to that question.
Yes, just on the basis of the X-rays, you might identify because it is having a very characteristic finding on the X-ray.
Yes, sir.
And once you relate it with what is being provided in the question as a language, you might come up safely with the answer that it is leg-Karl Perthes disease.
Perthes disease.
As far as pain in means limping and pain in case of a child is concerned, we are left with 3 differentials. You know, Tom Smith arthritis has been mentioned as the answer by means over here in the panel. You know, Perthes disease, SCFE and transient synovitis. These are the 3 differential diagnoses. As far as your question is concerned, these are the 3 findings which will always be provided in order to mark the correct answer. For Perthes, the age will always be provided in the segment of 4 to 8 years of age. For SCFE, the age will always be from 11 to 15 or 14 years of age. For transient synovitis, it could be any but under 15 years of age.
Right, sir. So all these are differentials of limping or hip pain in children. Three important differentials.
Three important differentials. All right. The age, we are not going deep into the reasonings like why in this age group it is very commonly affected. Second, always is the stereotypical sign, stereotypical association. All right. Which will always be provided in a question. Like for Perthes disease, thin built and hyperactive, or you can say overactive child. All right. This is a stereotypical picture of the child which will always be provided to you. Next, for SCFE, on the other hand, exactly opposite, like obese. All right. Obese or hypogonadal male. So this hypogonadism clinical features are going to be less likely in the provision. Like I have seen multiple questions asked like 13-year-old male having 86 kg weight. All right. And for transient synovitis, there is no such stereotypical finding. It can happen in any of the individual. And the third one are the specific clinical findings on the basis of which you will mark the answer finally. For Perthes disease, it will be limitation of abduction and internal rotation of the thigh. Simple. Because in osteonecrosis head of the femur, sir, in adults, the same
finding.
Same finding was there. This is osteonecrosis head of the femur in case of children. Epiphyseal head of the femur. All right.
Sir.
Second, in SCFE, there will be increased range of hip extension. You know, if the right-sided hip is affected, left-sided hip extension is, for example, 10 degrees. Here it will be 15 degrees. No, in any other condition, there will be no increased range of. Every condition of the hip joint goes into flexion deformity. This is the only condition where there will be an increased range of hip extension in comparison to the normal because of the displacement observed. Although with a revision class, we are not going to go deep into those displacement things. And finally, for transient synovitis, you know, there will be global restriction of all movements. That means all the movements are going to be painfully restricted and the limb would be kept in abduction and external rotation. Means the attitude with which the limb is going to be kept, it will be kept in abduction and external rotation. Now, based on these clinical evaluations, if we go back to the question, sir, in the question that is being written over here, 6-year-old is mentioned. So 4 to 8 is the criteria. Came with a complaint of lumping which is observed by the mother. Detailed history revealed that the child could be suffering from ADHD, thin-built overactive child. All right. On examination, there was no varus valgus abnormality, but the right-sided internal rotation and abduction was limited. By the time you even if you don't see the X-rays are just provided in order to confirm it further.
Right, sir.
You go with the answer of Leclerc-Perthes disease. But sir, it is also equally important to differentiate in between the X-ray findings of slip capitofemoral epiphysis as well as the Perthes disease, sir.
So first we look at the epiphysis. As the name suggests, in slip capital femoral epiphysis, the epiphysis is seen, but it is slipped, so it is in abnormal position, right? So what do you see here? As compared to the right side, so this is the right side, we see that if we draw a line from the superior surface of the femoral neck, it transects the epiphysis. But here the epiphysis is slipped downwards. So if we draw a line from the superior surface of the femoral neck, it does not bisect the femoral epiphysis. This is one of the signs that is named. This is the Klein's line. This is the Klein's line or line of Klein, and this sign is known as Trithoven sign. Okay, as compared in Perthes, you will see that the head is fragmented. The femoral epiphysis is fragmented and destroyed because it is an osteonecrosis of the femoral head. But in SCFE, the epiphysis is not destroyed in early stages of the disease. Sir.
Yes, as means this is how you will identify it in the basic differences, SCFE X-rays. So hopefully, sir, this differential is also over. Like
yes, sir.
Every student must now be able to answer it correctly.
Yes, sir.
Now the last question for today, obviously.
Yes, sir.
And this one is like again a very important differential. You know, a old age individual means elderly individual. They come with the most common complaint in the orthopedic OPD, and that is low backache. I mean, 90% of the patient in the orthopedic OPD are low backache
Low
patients.
backache patients.
All right. Like 82-year-old female came to OPD with the complaint of pain in the lower back, which is radiating to both her lower limb. Patient is not able to walk beyond 15 to 20 steps and is really relieved to some extent when the patient bends forward, all right, on leaning forward. On examination, it reveals that there is a loss of lower limb deep tendon reflexes and the SLR is found to be 90 degrees. Power is 5/5, that means there is no neurological involvement. X-rays are as follows. What is the most probable diagnosis that the patient could be suffering from? Now, you know, sir, what is being mentioned over here in the form of differentials are very closely associated features, like clinical conditions, like osteoporosis can happen, osteomalacia can happen, like multiple myeloma. Anyone can think of multiple myeloma also in
Yes,
the same
sir.
case.
Yes, sir.
And secondaries, obviously.
Yes, sir.
So how to rule them out and how to catch with the exact answer, catch up with the exact answer. So sir is going to explain you that what are the X-ray findings which are evident over here.
So here what we see on eyeballing is that there is osteopenia. Okay? The bone mineral density on looking at the X-ray per se, you say that the bone mineral density is reduced. Okay? You see that the vertebral bodies are little black, their cortexes are thinned out, not a typical X-ray normally. So it is an abnormal X-ray. We see that the bone mineral density is abnormal. And what do you see? You see this collapse of the vertebrae. You see that the vertebral body heights are markedly reduced. Okay? And typically what you see that the middle part of the vertebral bodies, they are flattened supero-inferiorly like this. Okay? Like this. And this what we have read, it is a sign, this is a codfish vertebra. Codfish vertebra. And we know that these type of vertebra are seen in osteoporosis. So typically the codfish vertebra per se is not important. What you have to see is vertebral body collapse and reduced bone mineral density. Okay. So the answer here would be osteoporosis. Sir.
Yes, sir. Thank you very much, sir, for explaining it. Like, you know, multiple vertebral bodies are getting collapsed without any history of significant trauma.
Yes, sir.
That is a possibility only if the bones are weak. And osteoporosis is a primary weakening of the bone.
Yes, sir.
All right. So this is one such consistent feature. All right. It is important to have a discussion on the other conditions also. Like one such condition is osteomalacia. Now, what is happening in case of osteomalacia is, all of you know that what is osteomalacia. It is a defect in the maturation of the bone. It is defect in the mineralization of the bone. And because of which what happens, that there is going to be pseudo fractures evident. You see, the basic difference in between osteoporosis and osteomalacia is that in osteoporosis, the entire density of the bone is reduced. While in case of osteomalacia, the proteinaceous matrix is normal. Only thing that it is the calcification or mineralization of the bone is imperfect. That is because in case of osteoporosis, what is happening? There will be a complete decrease in the density. The proteinaceous matrix will be reduced and attached to those minerals will also be reduced.
Right.
But in case of osteomalacia, proteinaceous matrix is relatively normal. Only thing is left out is the mineralization, adequate mineralization. Now, despite this bone is having a continuity, there is no break in it. But this segment of the bone is not mineralized. It is not going to be evident on the X-ray and will appear like a gap on the X-ray. And that is the reason why it is called as pseudo fractures. So these are not real fractures. These are pseudo fractures. Apart from this, based on the counterweight bearing phenomena, the acetabuli are protruded towards the medial aspect. So these are the X-ray findings. Osteomalacia is always identified by the medial by the X-ray findings. Means peculiar X-ray findings will always be provided to you in the question. Like the first X-ray finding will be loser zone. All right, loser zone, also known by the name of pseudo fractures. Pseudo fractures. Then the second one, this is also an interesting fact is that this is also called by the name of milkman fracture.
Yes, sir. Yes, sir. Right,
and
sir.
you know, there is a misconception associated with this, that is it seems that it is the fracture of the milkman. No, it is the fracture of the consumer. The milkman is providing the milk to, like, because if the milkman is adulterating the milk with too much of water, thereby depleting the quantities of the minerals which are essential for the bone mineralization, so the consumer is gaining those losers fracture. So it is due to the milkman the patient is having that fracture.
Interesting.
All right. The second one is the protrusio acetabuli, as we have just discussed, that these acetabuli, they will protrude inside. And the third one obviously is the triradiate kind of the pelvis. You see the inlet and the outlet. So the outlet is associated with the acetabuli, and both these acetabuli, because they are progressing medially, so there will be a triangular appearance of the pelvis, and that is the reason why it is also called by the name of triradiate kind of the cartilage. Triradiate pelvis. Sir, this thing can also be considered synonymous to or in appearance to champagne glass pelvis, but that word champagne glass pelvis is specifically given in case of achondroplasia. All right. So this is how osteomalacia X-rays are. And finally, these are the secondaries. Like in case of secondaries, all of us are aware that winking owl appearance and blind bat sign. These are the names which are provided to these X-ray findings for secondaries. And vertebrae is the most common bone recipient for any tumor. So what happens over here, if we compare these lumbar vertebrae, like this is vertebrae number 1, this is 2, this is 3, this is 4 and 5. In vertebrae number 1, these structures over here, these are known by the name of pedicles. So these are pedicles. And this structure which is clearly evident over here, this structure, which appears in between, like over here, this is a spinous process. And this is the entire vertebrae. Now, when we compare these pedicles with the eyes and the spinous process with the nose, it appears like a face of the owl.
Right, sir.
All right. So, in vertebrae number 1, this owl face means there is no feature which is deficient.
Both eyes are seen.
Both eyes are seen. Like in vertebrae number 2, both eyes are clearly evident. But in vertebrae number 3, the eye on the right side and eye on the left side is having a discrepancy. Like there is a pedicle which is visible over here, but the pedicle is found to be closed. It is not visible over here. So this is the appearance we are talking about. That is winking owl appearance. That one eye of the owl is closed. Blind bat sign means when both the pedicles in the single vertebrae are not visualized, then it will become a blind bat sign.
So it's not important to per se remember the name of the sign. These are not asked nowadays. In earlier questions it used to us, but important thing to remember on X-rays is that the involvement of pedicles is much more easily seen on X-rays in cases of multiple myeloma. So if as compared to body, so both metastasis and multiple myeloma can involve the vertebral bodies and the posterior elements. Earlier it was a concept that metastasis involve pedicles and posterior elements more than multiple myeloma, but these typical differences were in the time where MRI was not there. But in today's time, we know that both multiple myeloma and metastasis can involve both body as well as vertebral posterior elements. And this typical involvement of pedicle is more commonly seen on X-rays. Hence, we see the names of winking owl sign and blind bat signs.
So, if we go back to the question, sir, after this explanation, now it becomes much evident. It will become much easier for us to identify the question and the answer, mark the correct answer. So secondaries can be easily ruled out, like no
lytic lesion we can see in the bones, the cortex is maintained, so we don't suspect a secondary or even in a multiple myeloma for that case.
And the question for multiple myeloma is going to be entirely different.
Yes, sir.
We have already discussed that.
Yes, sir.
Osteomalacia related features, again we have already talked about. And in osteomalacia, one difference is also that the patient is going to be relatively younger, means in the middle age group, and the patient is going to be relatively bulkier in comparison to the strength of the bone. So this is how physical appearance is going to be identified. And the clear-cut answer for this question is osteoporosis.
Right, sir.
So hopefully, sir, if you want to say anything.
So this, I think with this session, our whole idea was to complete the entire important topics left. We have not focused much on the fractures aspect, but apart from fractures, INI-CET especially focuses a lot on arthritis, bone tumors, pediatric orthopedics, and metabolic bone diseases. So they are very important, especially for your INI-CET. And I hope you get a whole clinical vignette type of picture. We have tried to frame the questions in the form of clinical case scenarios, because that is how the pattern is going ahead right now. So those are my clinical remarks.
Yeah, seriously, sir. Like the questions are getting like what we see in OPD. what we see in IPD.
Right, sir.
They are converting it into a form of a question, simple.
Those days are back, long gone, sir, when one-liners used to come.
So the pattern is like, if you mug up anything and mark the answer, it's not done today.
And the questions options will also be confusing. They'll tell you all the type of arthritis that you have learned. So the examiner is trying to see how will you differentiate between close options. So I hope with this session.
Yeah, sir. But Tom Smith, this is sir. Dr. Meena has asked about like whether it is Tom Smith arthritis or not, where we were discussing about limping and pain.
Right, sir.
There is one confusion which is associated with Tom Smith arthritis. Tom Smith arthritis is the outcome of septic arthritis. The septic arthritis of the hip joint which had occurred during infancy. So Tom Smith arthritis could be diagnosed in 3 years of age, 4 years of age, 10 years of age. But it is only the sequelae of, it is the outcome of the septic arthritis which had occurred during infancy. So it is a controversial kind of,
Yes,
that is a different scenario, sir, where the septic arthritis in itself is a controversial term.
Yes, sir. Yes, sir.
Because it is a misnomer, septic arthritis. But hopefully you get the essence, like, we were not talking about the infective condition, we were talking about the limping and pain differentials in pediatric
age group. I think with this we can wrap up the session today, sir.
Thank you, sir. Hopefully this session it's going to be of help to the students.
Sir. Thank you so much and all the best for the upcoming INI-CET exam. Good night.
Good night.